Thanks for joining us, dear viewers. This is our special edition. Today I'm going to discuss with His Excellency Dr. Dereje Duguma, State Minister for the Ministry of Health, Ethiopia. I'm welcome your host. Have a beautiful time with us. Doctor, many thanks for joining me and welcome to this program.
Thank you.
Well, just to begin with, currently, what is the status of COVID-19 in Ethiopia?
Thank you very much. So, first of all, I want to thank OBN for working tirelessly day and night with all ministries, specifically with Ministry of Health, on COVID and other related health issues. So you have been instrumental in fighting the COVID in Ethiopia. So I just want to thank again. And concerning COVID updates, so far as we all know, it's almost 1 year and 4 months since the first COVID case emerged in Ethiopia. So we have been trying to prepare our service before COVID case came to Ethiopia, and then after the first case, and lately after so many people have been infected. So we have faced the approach into 3 parts. So basically, so far we have tested more than 2.8 million people in about 85 laboratories we have in the country. And out of these, so far 276,000 people have been found to be positive for COVID virus, and 4,320 people have been died since the first days which have been observed soon after the first case which was emerged in Ethiopia. And of course, the recovery rate is relatively good. It is 95%, so almost comparable to one of the best in the world. And the case fatality rate, that means people who died from the COVID, is about 1.7%. It's relatively lower when we compare to other countries, even US and Italy, where it is more than 10%. So, I mean, the young population in Ethiopia has supported us so that the death rate is relatively lower. So far we have seen 2 peaks. One of the peak is in July and August of 2012 Ethiopian calendar, whereby the case was really one of the highest. And lately, from February, between February and April, the cases has skyrocketed. So as we all remember, every day we have been getting more than 2,000 cases even sometimes. And the death rate was very high, as we remember, almost before 3-4 months. And it was about like every day, 40 days and so on. The positivity rate was like 30% at that time. So it was one of the highest even in Ethiopia and also in Africa. So those 2 peaks have been observed, and now we are approaching the 3rd peak that we'll talk later. But currently the cases, as you see, is lower. So every day it's about 100 cases, and the days rate is also sometimes even the day before yesterday it was 0 cases. So it looks low, but that's not the right figure. We are now talking about cases that we contact and that we test. But as we already see, the testing rate is very low. We are only testing a fraction of the community, a fraction of people that have been supposed to have acquired the disease due to several factors. So, I mean, it's very difficult to say the overall burden of COVID is as low as what we are reporting every day. But when we see different topics, different researches and surveys, the prevalence and the incidence of this deadly virus is very high, specifically in town areas, in vulnerable populations, in semi-urban and urban areas, and also in some regions in the city. So we can generally say that we are at risk. So WHO has said Ethiopia is around grade 3. So we can say definitely that the incidence of COVID is one of the highest in Ethiopia.
Previously, when the first case of COVID-19 in Ethiopia was reported, everyone was talking about that and everyone was implementing about the guidelines and principles of COVID-19. But now everybody is forgetting about that. Why this?
Yeah, such phenomenon is actually it's not only specific to Ethiopia. Many African countries and even developed nations have found those challenges in the combat against COVID. So basically in Ethiopia, as you have rightly mentioned, during the first season, everyone was aware about COVID, and everyone tries to comply to the directives and also to the rules and the regulations. At that time, actually, one of the supporting activity was the state of emergency. So the government has a state of emergency in place, and the measures were very strict, and that really supported us to prevent the transmission of the virus. And we have got a time actually to build the capacity of the health sector in the meantime. And also, previously, the government at all levels gave due attention to prevention activities for COVID. So the face mask use was good, hand cleaning and disinfection was good, the social distancing and everyone is good. And as you know, the approach was one of the the whole of society or the whole of government. At all levels, the government make COVID a priority agenda. And as you remember, the business were closed in most of the areas. Transportation was closed. But you know, we are in the third world, we are one of the least developed nations. So closing everything has its own social and economic impact. So to prevent those social and economic impacts while preventing from COVID, the government decided to open up some of the economic activities, including restaurants, cafe, hotel, and also transportation. You know, 1/3 of the population was students. The schools were closed and everyone was at home. So we also tried to open the school again. So whenever a school is open, people tried to go out without mask. The complacency came into picture. And also the other serious problem we have is the law enforcement is very weak in Ethiopia. In many countries, that was not the case. I mean, people will get a fine if they don't wear mask, but it's very difficult to operate in that level in Ethiopia. You know, the daily activity in the community is really very complex and dynamic. Assume that closing business in Addis Ababa, in Mercato, and so on. I mean, the nature of Ethiopia is sometimes difficult to make laws very strict. So law enforcement was very difficult, and policemen and other people who want to work on that has their own difficulties. And also the other challenge we have been looking is the government's attention to COVID has declined for many reasons. One, we have different holidays, and there were different activities. And for example, the days of the late artist Hachalu, during that time there was a very major people went to the street and so on. And also during holidays, people forget to wear masks and so on. So the problem is from the government side, leadership at all level didn't work very seriously on COVID. So they feel that there is no more COVID in many parts of, especially the rural part. And also from the community, there was complacency. And also from the health sector, we tried to focus not only on COVID, but other health issues, including different emergencies. And there are different security issues in the country, as you know. And even last time there was election. All these issues made the whole system not to function properly. So there was a complacency. And now our data shows that the face mask utilization in Addis is only 50%. And in other parts of the cities in different regions, it's about 10, even less than 10%. So the challenge is there. And now we are working with Prime Minister Office to reinstitute again and to enhance the preventive activities. The Attorney General and the Federal Police Commission have pledged to work with us to seriously work on the law enforcement. We want to again make an awareness creation for the community, and also the health sector will in the future going forward will work on the preventive activities very well.
Well, in a nutshell, how Ethiopia is managing the COVID-19 right now?
Ethiopia has a very good experience in managing COVID-19. You know, as I've already said, we have more than 100 million people, and most of the communities have low livelihood, and it's very difficult to keep physical distancing in Ethiopia. Hand cleaning is, it's very difficult to avail at all level because of the very challenge we have. Most of the people are, more than a quarter of people live in poverty. So in a low resource setting area, preventing COVID is a challenge by itself. But Ethiopia managed very well. One of the serious work we have done is to raise an awareness of the community. All the media speak about COVID. We have used social media. We have also tried to involve religious institutions and also key public figures to speak about COVID. So awareness creation, risk communication of COVID was one of the serious issues we did previously, and also we are working on that. That is one of the good achievement we have. So survey shows that now 97% of the population knows about COVID, the transmission and the prevention activities. But practically working on that has a challenge by itself, but still the awareness is very good. The other issues, testing, we have increased the testing now. So currently we have 85 laboratories, and we have also important now antigen-based rapid diagnostic test that can tell you the result in just 30 minutes. And we have started working on that. So people will know their result just in a matter of minutes. So that will also improve and help us in prevention. The other thing is the treatment facilities. So far we have about 20,000 beds that have been prepared for COVID treatment. And we have changed the Millennium Hall to a hospital, whereby more than 1,000 beds are serving the population. We have field hospital, and also other hospitals have started treating patients in almost all areas. And even our plan is now to integrate COVID treatment with other treatment. So every hospital is mandated to have a different block whereby patients can get treatment. So our people should get the COVID treatment in a nearby facility. So by doing this, we have tried to decrease the transmission from person to person, and also the treatment by itself is quite very important. This is what we are doing. And also now, recently we have tried to vaccinate vulnerable population. The vaccination by itself, so actually for the decrement of the cases, vaccination has its own role. And now we have vaccinated more than 2 million people in Ethiopia, and most of them are frontline workers, including health professionals. So when we protect professionals from COVID, it's not only protecting the health professional, we'll also protect the community, because most of transmission occur between patients and health professionals. And also we have tried to mobilize many resources for COVID, from private, from the government, from different NGOs, and from different international donors. And we have the resource mobilization was one of the serious issues that we are working now. And I'm sure all these activities by different partners, government, NGOs, international and local NGOs, from the community, from our media, from our public key people, have kept the transmission of COVID into one of the lowest in Ethiopia. And the days, for example, so far we have only 4,320 cases. These days can be counted, for example, in India in 1 or 2 days. So we have did very important jobs in preventing the days and the transmission, but still, it's a big country, we have to do more.
As COVID-19 is alarmingly increasing in Ethiopia, what is planned in your ministry or as the government in vaccinating the whole population?
Vaccination is one of the best innovation in 2021. So previously, for producing a certain vaccine, different pharmaceutical companies may need about 10 years maximum and minimum 5 years. But now in 1 year, the world has tried to produce a vaccine. These vaccines are quite safe vaccines so far. So we have a platform called COVAX. In this COVAX, more than almost 192 countries, including Ethiopia, are part of it, and they approach, all these countries approach pharmaceutical companies together. So with the economies of scale, they will get enough vaccine with a low cost. So countries will support each other in the platform. So we are part of the platform, and so far we have got 2.4 million vaccines, and we have vaccinated 2 million people in Ethiopia. Those vaccinated so far are vulnerable group, health professionals and people with comorbidities and age more than 50, And also all population with age more than 60, almost most of them have got now vaccines. Actually, this group are vulnerable to deaths by COVID. That's why now the death figure is as low as 10 per day in Ethiopia. And actually, as you have said, we have to achieve like 80%. That's called herd immunity, whereby the transmission can be really go low to zero or negligible. That's called herd immunity. But to achieve that, one of the challenges is the availability of the vaccine. That is a challenge we have not only in Ethiopia, but also globally. Our plan is to vaccinate 20% of people at the end of 2021. And now we are working on that. And the second plan, phase 2, is to vaccinate 50% of our people at the end of 2022. And then beyond 2022, we'll achieve like 90% of population to be vaccinated. Actually, this depends on the global availability of vaccines. So far, the vaccine shortage is one of the serious shortage we have. The developed nations have more vaccines and the least developed have only few vaccines. We are working in the platform on this, but our plan is to vaccinate 20% at the end of 2021, and we are working on that seriously.
What about the fairness when accessing the vaccine for all people of the country, for all citizens of the country? What about the fairness?
Yeah, that's one of the challenge. Actually, the availability is one, and I'm sure the availability will be improved in the coming months and in the years because there are many vaccines. So far, about 10 vaccines have got WHO certificate, but more than 100 are on trial, and I'm sure many vaccines will come to the market. But as you have rightly said, the fairness, the equity is the challenge we have. Actually, it's not the fairness issue, is not an issue of COVID vaccination, but in health, in areas, one of the challenges we have in the world is an equity and fairness issue. So, for example, now some of the countries, including Canada, they have more than vaccines 4 times more than their population, and some of them have there in store, and even it is expiring. But the other nations, including most of them in Africa and in Asia, we are begging for more support. As a challenge, the global fairness is a challenge, and the COVAX platform is working on that, so that all and WHO itself is working on that, so that the least developed nations have got their share. And also, we are trying to communicate with pharmaceutical companies that produce vaccines to buy from them. So far, it's coming by COVAX platform. We are not buying, and now the government of Ethiopia wants us to directly buy from companies, and that also support us. But in country, the fairness is managed very well. So our criteria is set very clearly: age more than 60 without any comorbidity, age more than 50 with comorbidities, and health professionals in all regions are getting the service. And we are distributing vaccines to all woredas and to all regions based on the set criteria. And in Ethiopia, there is no question with fairness. I mean, every region and every woreda is getting their fair distribution of drugs, vaccines. But the biggest challenge is at global level, and WHO, other big partners, international community, and the Gavi the COVAX platform is working on that to at least improve. I mean, it's difficult to completely remove the fairness issue, but I'm sure we'll improve in the coming months and years.
Well, in relation to the COVID-19 vaccine variant, is there any possibilities in Ethiopia?
Ethiopia is a big country, and I always feel that Ethiopia will be a door to Africa. We have a very famous Ethiopian Airlines that have been instrumental in transporting COVID materials in Africa and also in the whole world. And we have a very motivated and ambitious leadership that can plan ahead. And we have many institutions, and our community is supportive, so I'm sure we can do more. For example, with mask, when COVID hit Ethiopia, the mask we have was almost negligible. and even the cost for masks, I mean, people buy with a very high price masks, and then we started to produce masks. Now in Ethiopia, we have already stopped importing masks. We are producing in our industrial park. That's one of the best achievements we have. And then about kits. Kits in East Africa, Ethiopia is the only country that's producing test kits for COVID. So BGI is working on that in Bole Lemi Industrial Park. We are producing kit, and actually we're trying now to export the kits. And now it's time for Ethiopia to produce vaccines in the country. So two governments have approached us. One is Israeli government and also China. We are working with this government, not only with other countries, but also with many other big partners that work with Ethiopia. For example, Gavi works on vaccines mostly, and so they want Ethiopia to have vaccination production facility here. So the possibility is very high. We are working on that, and I'm sure we will have vaccine producing company, and it will not end on only COVID vaccines. You know, we have more than 12 vaccinations for different disease entities, and I'm sure next to COVID, our plan in the coming 10 years is to produce different vaccines in Ethiopia, so we will make it reality in Ethiopia.
What about the vaccine quality that Ethiopia is currently accessing to its people?
These vaccines, in terms of quality and safety, it's very important to look for the quality and the safety parameters of every drugs, specifically vaccines. So if there is any problem with safety and quality, I mean, the disadvantage weighs, and that is really, it will create a problem in the country. So what we are doing right now is, first of all, we will share the data from WHO and the other global partners. So WHO has gave for about 9 vaccines emergency list, emergency drug vaccination list, and 2 vaccines which are now being enrolled in Ethiopia, namely AstraZeneca and Sinopharm. They have been enlisted by WHO to be a safe and quality one. So WHO gave us data of these 2 vaccinations, and we only accept WHO certified vaccinations in Ethiopia. So that makes us perfect in that term. There are some countries that use their own mass vaccines or vaccines that have not been certified by WHO, but for us, we are very strict on WHO parameters. The second level for checking quality and safety is our Food and Drug Authority, which is called FDA. They are continuously working with WHO and the other pharmaceutical companies, partners, and so on, to have the full profile of those vaccinations. And even they send a team of experts to companies that produce those vaccines. So we have all the data of these vaccinations right away from their manufacturing and then distribution, storage, and so on. So we have full data. So far, these vaccines are safe, and they have good quality in terms of the safe parameter globally. This is not the end of the story. After people get this vaccination, we will follow all those people. I mean, the 2 million people, their database is already in our hands. We will see if there is any adverse drug effect from the vaccinations. We'll see if there is anyone who have been died, any complications related to the vaccinations. And if it happens, we'll try to vigorously check what is the problem with the drug. You know, these vaccines have been produced in different countries. They may not seriously work for our community or for the virus which is in Ethiopia. So we always want to cross-check those things. And if there is any serious issue, we give the information to WHO and to authorities at different level of the country. So we are working seriously on them. And so far, those vaccines are quite safe and adequate, not only in Ethiopia, but also globally. So our people should have no worries on safety and quality.
Well, coming to the vaccine hesitancy, it is clear that vaccine hesitancy has been widely seen in the world and in our country, Ethiopia too. How do you think this habit can be changed and a vaccine will be improved?
Yeah, this is actually a challenge for many countries, including Ethiopia and also even many countries in Africa. For us, especially during the first rollout of the vaccination, we have a very serious challenge. And the first challenge came from the health professionals because they know side effects and so on. So there were serious challenges, and we have tried all our best to improve the vaccine hesitancy. So what we did was the media engagement. So we have tried to talk about the virus, the benefits of getting the vaccination through our media, and also have tried to engage key public figures, religious figures, and also leadership, so that the people can feel that the drug is okay. If those public key figures receive the immunization, I mean, the people will definitely know that that's a good drug. And also we are trying to, as I've said, to check the safety and the quality. We are every time we are following those clients who have received the vaccination. So we are also informing everyone that the drug is quite safe. But still, media engagement is quite very important. I mean, in many regions, and especially in urban areas, including Addis, things are improving very well. But still, in some woredas where the literacy, health literacy in general is low, the hesitancy is there. For example, in Afar, still the acceptance is about 50%. So we feel that we have to work on communication, awareness, and also not only at community level, but the religious leaders themselves, sometimes they are challenge for us. The leadership, they should convince themselves and the community about the benefit of the drug. There are challenges, but still we are working with that. I'm sure we will improving the hesitancy in the coming months.
Well, apart from COVID-19, coronavirus, non-communicable diseases like that of hypertension, diabetes, cancer, and other diseases has been highly increasing in Ethiopia. What do you think the reason for this?
For many years in Ethiopia, the distribution of communicable diseases have got the highest share. TB, malaria, HIV, and other communicable diseases have got one of the biggest prevalence and incidence in Ethiopia and also in many other African countries. But recently, non-communicable diseases like diabetes mellitus, hypertension, cancer, injuries, heart, kidney diseases are alarmingly increasing. Actually, based on the surveys and the data we have and also international data we have, the challenge, the reasons, the risk factors are there. One of the exacerbating or the factor is the urbanization. So the way of living in rural area and in urban area is quite very difficult. So now many towns are emerging, cities are emerging, and most of our people will migrate from rural area to the urban area. And in urban areas there are a lot of risk factors that predispose us to non-communicable disease. So the basic change is the urbanization way of living. The other problem we have is the dietary related issues. So the foods we are consuming every day. So most of them are not natural and organic. We buy foods from supermarkets which are imported from different countries. So the travel time, the environment, and everything will affect the disease itself, the storage, and so on. And also we consume salt very highly. So Ethiopia is among one of countries whereby salt consumption is quite very, very high. And also trans fats, which directly predispose us to non-communicable diseases. So we consume fat. In general, the dietary habit of Ethiopians is quite very limited one. So we don't usually consume fruits and vegetables. Nutrient-dense consumption is not a habit for Ethiopians, specifically in urban areas. Even the diet shortage, the food insecurity itself, this will all exacerbate us to non-communicable disease. And also there are a lot of behavioral related factors. Smoking. even though we are working on that now, but the smoking rate is alarmingly increasing in urban areas. The youth are becoming smokers from time to time. Alcohol drinking is actually in rural areas also is a very big habit. So all these things predispose us to NCD, the sedentary life. So we are not walking now, we are not running. People most of the time, especially in urban areas, they use taxis, bus for transportation. So the habit of sedentary life and also not exercising, mobilization, social mobilization, sports, and everything is not adequate in Ethiopia. So all these things will predispose us to NCDs. And also there is no habit of medical checkup every year. In developed countries, people go to facilities at least twice for the general checkup, but this is not a trend in Ethiopia. Even from the health sector side, one of our serious agenda in the coming 10 years is to have screening for these NCDs. So, for example, now for hypertension and diabetes mellitus, about 30% of the population, they don't know their status. And this, for example, hypertension is a silent killer. Sometimes when they come with symptom of hypertension, almost one of their organ have been damaged. So most of the time it's a late diagnosis. So there are a lot of risk factors, and now we are working on them. It's now an agenda for the government. So previously we focused on communicable diseases. Now we are giving due focus for non-communicable diseases, including the awareness creation, media engagement, and so on.
What is the 10-year perspective plan of the Ministry of Health, Ethiopia?
We know the government has 10-year development plan. We can say it's a prosperity plan whereby Ethiopia becomes one of the middle-income country lists after 10 years. So in line with the government plan, we have also produced our prospective plan. So basically we have classified into two, the first 5 years and then the last 5 years. The focus areas are, one of the focus areas, as I've rightly told to you, it is to focus on non-communicable diseases, specifically to have tertiary hospitals. So in Ethiopia, we have only few specialized hospitals, and most of them are found in Addis, like Tukur Anbessa, St. Paul, and so on. We want to have more big facilities in the regions and also in different zones and the woredas. So we want to have very big hospitals in the tertiary care areas, medical tourism areas in Ethiopia. That's one of important area. So we have already started. Last time you have seen that there was a very big initiative by our Prime Minister. Roha Medical Complex have been started to be built. That will be a medical tourism center. And also IGAD has gave us a chance to have one of the biggest cancer center, oncology center, also in Addis. I mean, the government will also add upon that. So highest quality tertiary comprehensive care will be our attention in the coming 10 years. The other focus is in terms of human resource. The number of medical doctors, specialists, and other professionals is one of the lowest when we see the distribution of them. Most of them are in cities. So 400 million people, still we have lowest professionals in number, even based on WHO scale. So we want to have more health professionals, not only in quantity, but also in terms of quality. So we want to have one of the best teaching hospitals whereby our professionals have very good quality education. So we will want to improve the human resource development in Ethiopia. The other issues, drugs and the medical supplies. Now more than 80% of drugs and the medical supplies are imported from abroad. So we want to have pharmaceutical companies that can produce drugs and the medical supplies in Ethiopia. And also we want to modernize our traditional medicine. And at the end of 10 years, I hope at least half of drugs will be produced in Ethiopia, so that we don't have any problem with hard currency shortage, transportation shortage, and so on. So if you go to community and ask them the challenge they have in health sector, the serious question is shortage of drugs. So I'm sure we'll work on this area. The other area is we want to have a resilient health system that can cope up with any emergency. You can see COVID. COVID has disrupted a lot of things in Ethiopia and also in different countries. So in some countries, the health sector cannot produce any deliverables beyond COVID. Though the other health services, for maternal service, for child service, other services have been collapsed in many countries. Actually, we have tried to manage them. So we do want to have a very modern, comprehensive emergency system whereby if any emergency occurs, it could be man-made or natural, it could be an epidemic, whatever, the health system should absorb the shock, and we should continue and maintain all other services. These are some of the areas that we have put in our 10-year prospective plan, but still we will focus on preventive services that will get their attention. The health extension program, the primary health care level, the services in health centers and hospitals, and also awareness creation and family education, family-based health approach is quite very important. I mean, the government has to plan, but without involvement of our communities, we will not attain anything. So community engagement should be the pillar of our plan, and we have serious attention on those areas.
Well, at the moment, what is the status of Sakota Declaration all about the stand?
As we all know, Ethiopia has one of the highest malnutrition figures in Africa and also in the world. And the rate of stunting is one of the highest. It's about 37%. Wasting and also acute malnutrition, chronic malnutrition, because of the food shortage and insecurity, because of the global warming and so on. I mean, we do have a lot of challenges in terms of nutrition. So malnutrition is underlying cause for diseases in children less than 5 years. So the government has given due attention for malnutrition. So there are 3 forms of those activities. One is we are working with other sectors. So it's a multi-sectoral approach. For nutrition, we have to work with other sectors. I mean, it's not only health sectors that should respond to nutrition. Education have their own stake. Women and the child health, child ministry, MOLSA, Ministry of Labor and Social Affairs, the PM office, and everyone has stake in nutrition. So we are working on the multi-sectoral approach. And also, in Ethiopia, we have many emergencies, man-made and natural. So emergency nutrition is also another important work that we are working on. But specifically, this Sakota Declaration is quite one of the most important commitment from the government. So it started in Amara, in the Tigray region, in 40 waradas. The plan is to make stunting zero at 2030, and so far about 5 years have been elapsed since it already started as a pilot. So the current status is now we have examined, we have analyzed the achievements so far, and we are scaling up to 200 waradas in all parts of the region apart from Tigray and Amara. The results are really promising. One of the issues we have seen that it is a multi-sectoral approach. About 7 sectors are working in Sakota Declaration together. We plan together. The budget is together, and also the report is the same on that line. So we have one plan, one budget, and one report principle. And so far from our side, the malnutrition rate have decreased in those 40 waradas. Educational sector have also improved very well. So at every school there is a show up for nutrition, and every community has now started to have vegetables and fruits in their garden. Irrigation activities have increased so much, and the food availability, food production, and productivity has increased in those 40 waradas. So the community, even sometimes, innovation and technologies have been accepted very well in those communities. So the results are very encouraging, and I'm sure using the Sekota Declaration platform, we can reach most of the undernourished children in the coming 10 years. And also it's part of the 10-year plan. So yeah, it's promising, and we have to monitor, and we have to evaluate in the scale-up process.
Well, last time Ethiopia signed and launched the UN professionalism. What is important for this country?
Yeah, in many UN treaties and also UN action plan, Ethiopia is one of the foremost signatory. And also for the same for professionalism, Ethiopia has signed, and it will support us especially for human resource development and administration. So, I mean, in Ethiopia we need more professionals, not only in quantity, but also in terms of quality. We do have health professional conduct and ethics. So in terms of this, the act that we have already signed and agreed will support us. That will really enhance the development of human resource, specifically for higher professionals, including specialists and other medical doctors. And also, this will support us in sending our professionals to different countries so that they get experience, and also it will enhance to import different medical specialists and professionals from different countries to Ethiopia, so that we can really learn from each other, and that will finally will improve the health access, quality, and service for our community.
What is exactly the strategies to end up malaria from Ethiopia? What is exactly the strategy that your ministry is currently undergoing?
Yeah, the strategy we have for malaria is called Malaria Elimination Strategy. So this Malaria Elimination Strategy is a 5-year strategy, of course, from 2021 to 2025. We have already started the implementation 5-6 months back. So we are speaking now elimination. Previously it was a control, and now most of the cases have been controlled, and now we want to eliminate malaria from Ethiopia. Some of the countries have already did. For example, China last time declared that they have eliminated. And also in Africa, there are 2-3 countries that are eliminating malaria. And Ethiopia is actually on the track to eliminate malaria. So it has its own criteria and objectives. And now we have already started the implementation as a pilot in 68 waradas. And so in these waradas, if there is a single malaria case, we will analyze what is the cause. It could be vector-related issues, it could be biologically, or it could be from drug and so on. So we will analyze, we will investigate the foci, and then we will respond accordingly. So in the strategy, one of the biggest issues is to control vector, malaria vector. So we will work on that. And the other thing is to give ITN, insecticide-treated nets for all families. Now, actually, we are working seriously on that. But actually, it's not only delivering ITN for the community, but the utilization is quite a challenge. Our people may get the bed net, but sometimes they will not utilize it very in a proper way. That is another work we can do in the strategy. The other thing is this chemical spreading in different parts, specifically around the vector area. So we are also working on that seriously. The other thing is we are decentralizing the treatment to all health centers and health posts. So everyone who have been suspected with malaria should receive and get access to drugs at health post level and at health center level. So if they get adequate and immediate treatment, I mean, the days from malaria will go to very low. So we are working on that. In general, surveillance, I mean, daily reporting of cases, daily follow-up of the cases is very important. So the surveillance part is one of the focus area in malaria elimination strategy. So in the coming 5 years, we want to eliminate malaria from most of, specifically from the highland areas of Ethiopia. And then I'm sure probably in 10 years, Ethiopia will get certificate of eliminating malaria from this nation.
Good luck. Coming to the child and maternal mortality, status and works underway in your ministry in controlling problems related with the malnutrition. What kind of works has been underway right now?
As we all know, previously in Ethiopia, the mortality, child mortality and the maternal mortality were one of the highest. But with jobs that have been done previously, it's now decreasing to a low level. But still mothers are dying, children are dying. So what we are including malnutrition, I mean mortality of children specifically is almost related with malnutrition. So what we are doing is for mothers specifically, the antenatal care, the postnatal care and facility delivery are quite important areas that we want to improve. So now about 70% of our mothers are delivering in facilities. That's quite a very great achievement. Probably if you go 10 years back, it's only 10 or 20% that deliver at facility. Most of our mothers, including our own mothers, delivered us at home. But now most of them are coming to facility, and we want to make 95% of mothers, especially in the 5 year that we are going to embark on, 95% of mothers should deliver in facility. Then the mother will be safe, and also the infant, the neonate will be safe. That is one of the area. For this purpose, we are constructing maternity waiting areas, especially in rural areas. The women are very far from facility, and sometimes these geographic problems are there. So they should come when their expected date of delivery approaches. They come to facility and they stay there for 1 or 2 weeks before they deliver. So we are constructing maternity waiting areas. Another important thing is ambulance service. Over the last 1 to 2 years, we have procured and distributed more than 3,000 ambulances for woredas. And now in a woreda, you can get 3-4 ambulances. So these ambulances serve the mothers 24 hours. That is quite very important investment, and mothers are benefiting from it. So in a matter of 30 minutes, 1 hour, mothers will reach at facility. Other important thing is facilities should give quality and accessible service. Now, the cesarean section or delivery by operation is only given in hospitals. And now in health center, we have started to give operation service. That's called cesarean section. That's quite an important investment too. For child days, what we are working is on nutrition. So screening of malnutrition and then supplementing with food is very important. We are working on that, and we are screening especially children under 5 years every month whether they have malnutrition or not. And if there is any sign of malnutrition, they will be treated for that. Also, pneumonia and diarrhea are killers of children under 5. For pneumonia and for diarrhea, as much as possible, we are placing all commodities, drugs at health post level. So at health post level, you can get ORS, it is life-saving nutrient. You can get amoxicillin at rest. So the basic important life-saving drugs are now at health posts. So health extension workers are trained on that. Whenever they go to visit from house to house, they screen children under 5 and they give medication, or they link those seriously ill to facilities at health center or at hospital. So we are doing on that. And also, importantly, we are working on neonatal intensive care unit. Specifically, the neonatal disease is not progressing very well. So NICU, or neonatal intensive care units, some children and the neonates, they have very serious illness. So they want ICU service. So in 80 hospitals, we have started neonatal intensive care unit. So that will decrease maternal and child mortality in Ethiopia. And actually, in Africa, Ethiopia did a great job in decreasing maternal and child mortality. But still, in the coming 5 and 10 years, our goals are very ambitious, probably similar to what developed nations have. But government, the people, the community in general, the media, by creating awareness, and also partners, local and international, have to join us in decreasing maternal child mortality, because mothers are everything for us. I mean, whenever a mother dies, it's not only that mother. I mean, that house has been already degraded. So we will give due attention for maternal and child health.
How do you tell us the current status of TB, malaria, and HIV in Ethiopia?
Yeah, for malaria, as I've previously talked to you on the malaria elimination, malaria has, the distribution is now very low. And previously, before 10 years, malaria was one of the killer. Probably in certain district, you can have a lot of diseases and a lot of illnesses by malaria. But now it's very low, and it only happens in areas where there is water accumulation, where there is very low knowledge about malaria. Otherwise, in most parts, malaria is becoming a history in some part. So we just only get few people who have a tribal history. But in some areas, specifically developmental areas, in irrigation areas where there is stagnant water, comfortable area for the vector multiplication, still there is a risk. The risks are usually in the western part of Ethiopia, where there is heavy rainfall followed by dry season. We are working on that specifically around irrigation areas. Now we have a lot of irrigation areas, so we also have some emerging cases on that line. So the figures are quite very low, but still we focus on areas which are already prone for malaria distribution or transmission. For TB, globally, there are 30 countries having very high load of TB, and Ethiopia is one of them. We are on number 22. So the work on TB still needs very big endeavor. So basically now one of the serious issues is detecting TB from the community. So this chronic cougher, people who cough for more than 2 weeks have probably tuberculosis. And our health extension workers and other health professionals, they should go house to house and identify people who cough, and then they should start their treatment. They should be diagnosed and then should be put on treatment. But we are only detecting about 70% of them. So the rest 30%, we are not reaching them. This is the TB detection rate is still not satisfactory. We have to work on that. But you know, the MDR TB, multi-drug resistance tuberculosis, is decreasing seriously. That is a good achievement as Ethiopia we have. But for TB, detecting TB and putting people on treatment, following them, because some of patients, when they feel that they are okay, they discontinue the drug. You know, the drug is given for 4 to 6 months. They discontinue after two months. So we have to also work on dropout of or drug continuation. For HIV also as malaria, it has been not only health threat but also social and economic challenges related with HIV was one of the highest. But you know, Ethiopia did a great job, specifically in Africa. Still in many other African countries, HIV is public concern. But in Ethiopia, the mortality and the morbidity related with HIV have decreased in a big figure. Now the prevalence is 0.9%. Is even less than 1%. So our strategy is to control the epidemic. We are on epidemic control. But currently, the case is emerging in urban areas. For example, in Addis, it's more than 3%. In Gambela, it's more than 4%. And also in other urban areas, HIV is alarmingly increasing. And also in some segment of the population, for example, female commercial sex workers, more than 20% of them have HIV. This is a late incidence which is really rising. Long truck drivers, daily laborers, all these segments of population have increased incidence in HIV. So HIV now needs another political agenda. The government at all level should give priority for HIV. We have to mainstream HIV. The political attention to HIV has really decreased a lot. So if you talk with anyone, they say that no, HIV is not our problem. But still, HIV is spreading in community level, especially at urban areas and in some segment of the population. So it needs again a very concerted effort.
As indigenous knowledge should be promoted, to what level do you think we have to use our traditional medicines by integrating them with modern or conventional medicines?
Yes, right. You know, the benefit of traditional medicine is quite understandable for the ministry, And we know that the Asian experience, especially China, has benefited a lot from traditional medicine. And in Ethiopia, we have a big indigenous knowledge specifically on traditional medicine. And I'm sure that most of the Western countries has got the experience even from many African countries, including Ethiopia. And when we talk with our forefathers, with our elders, they tell you a lot about indigenous knowledge, specifically on traditional medicine. And still many population are rural areas. They go to traditional healers to access drugs still, even in a modern time. So it's a must to integrate traditional medicine with modern medicine. Yeah, in Ethiopia, we have started now working on that. And we have also a 5-year traditional medicine roadmap. It is actually under Ethiopian Public Health Institute. We have one big directorate on that, but we are working together. And also there is Traditional Medicine Association, whereby traditional medicine healers have their association, and we are working with the association. So our plan is to modernize those traditional medicines. And now we have got many traditional medicines from the association, and we are trying at least to characterize those traditional medicines in terms of physically and also their content, the hazards related with those drugs, and also the toxic levels and so on. I mean, modernizing traditional medicine it needs a very high capacity. It will not end in Ethiopia. I mean, you have to get it to modern laboratories in different parts of the world, in US, to England, and to many other countries, so that the drug will benefit all people in the world, not only for Ethiopians. So we have tried, but still we need more capacity, more scientists, more knowledge, and based on the strategy, we will work seriously on that.
Well, I'm going to end up my questions, but lastly, while the ratio of physicians in Ethiopia and the population in our country is below the standard, in number of health facilities are running without enough professionals, why fresh physician graduates are not getting placement. For example, we've seen complaint of fresh graduates in Badar University and other places. Why this?
Yeah, as I've told you, the rate of physicians and other medical professionals to the general population is one of the lowest in Ethiopia, even based on the sub-Saharan figures, let alone the world figure. So WHO mandates countries like Ethiopia to increase their human resource, specifically nurses, midwives, doctors, and specialists. So based on this, we have trained many medical doctors. Previously in this country, medical doctors are very few in number. I mean, in a big hospital, you cannot get more than 5 doctors. But now, in one of the most remote primary hospital, you can get about 10 medical doctors. This is just because we did a lot in increasing the number of medical doctors and specialists. So every year we are training more than 2,000 medical doctors. 2,000 medical doctors are graduated every year now in Ethiopia. About 11 universities are now graduating medical doctors. So the number has increased a lot. But the infrastructure we have is not improving in that accordingly. The hospital numbers are still very few. We are not sending medical doctors to health centers. They are only placed in hospitals. So the infrastructure we have, the health facilities are not still occupying the many doctors that we are producing. That is the basic challenge we have. The other challenge is financial. I mean, these medical doctors, they need salaries and different payments from the government. But the regional governments are not giving more fund for the health sector. So, I mean, without finance, it's very difficult to recruit medical doctors. So these are some of the challenges we have. To curb this problem, what we are doing is now we are communicating with the regional government to increase the share of budget for the health sector. And now, I mean, this is a new year, 2014. So during planning phase, they have started to improve the budgeting for them. And also for the COVID and so on related matters, we are hiring medical doctors as a contract. And then we can elongate the contract after every year. So we're also working on that. The other thing is we are allowing fresh medical graduates to exercise privately. We have already finalized and ratified a rule and a directive. Then we will allow them to privately exercise their profession. That will also decrease the challenge we have. And also with Ministry of Labor and Social Affairs and also job opportunity, our plan is to control, to export medical professions in a controlled way. I mean, they can go to many different, for example, the Arab countries, Saudi Arabia, they need many more nurses and medical doctors from Ethiopia because they know that we have many of them and the education quality is one of the best specifically for nurses and for medical professions, and we are also working with them and we can export some in a controlled way to different countries. So the challenge is there. The problems are basically the financial and also the infrastructure challenges we have, and we have many solutions to give for them. And I'm sure all our health professionals should exercise before they forget what they already learned during their academia. So I'm sure we'll respond also to that.
Well, Dr. Dereje Duguma, the State Minister with the Ministry of Health Ethiopia, I really appreciate and thank you very much for joining me and for your wonderful thoughts again.
Thank you.
Dear viewers, this will bring us to the end of this edition. I'm hosting this program for you. Have a beautiful day.